Welcome to Pediatric Case Review. Today we'll explore patent ductus arteriosus, a common congenital heart condition in pediatrics. This lecture will provide essential knowledge for pediatric residents and fellows covering embryology, clinical manifestations, diagnosis, treatment options, and prognosis. A premature infant born at 28 weeks gestation is at increased risk for patent ductus arteriosus due to which of the following mechanisms? A. Decreased pulmonary vascular resistance. B. Decreased prostaglandin sensitivity. C. Increased sensitivity to oxygen. D. Decreased prostaglandin metabolism. The correct answer is D. Premature infants have decreased prostaglandin metabolism. The ductus arteriosus normally closes after birth due to increasing oxygen levels and decreasing prostaglandin E2 levels. Premature infants have immature lungs that cannot efficiently clear prostaglandins, leading to persistent ductal patency. A 3-day-old term infant has a persistent patent ductus arteriosus. In fetal circulation, what was the primary function of this vessel? A. Shunting blood from right atrium to left atrium. B. Shunting blood from pulmonary artery to aorta. C. Shunting blood from aorta to pulmonary artery. D. Providing blood flow between the ventricles. The correct answer is B. In fetal circulation, the ductus arteriosus shunts blood from the pulmonary artery to the aorta. This right-to-left shunt allows blood to bypass the non-ventilated lungs as the fetus receives oxygenated blood from the placenta. This prevents unnecessary blood flow to the collapsed fetal lungs. A 6-month-old infant with moderate-sized PDA develops symptoms of heart failure. Which hemodynamic change explains this complication? A. Right-to-left shunting leading to cyanosis. B. Left-to-right shunting causing pulmonary overcirculation. C. Bidirectional shunting causing mixing of blood. D. Decreased systemic blood flow to vital organs. The correct answer is B. After birth, as pulmonary vascular resistance falls below systemic vascular resistance, the shunt direction reverses to left to right. This causes blood to flow from the aorta back into the pulmonary artery, leading to pulmonary overcirculation, volume overload of the left heart, and eventually heart failure. A 2-week-old full-term infant presents with tachypnea and poor feeding. On examination, you note bounding peripheral pulses. Which additional finding would most strongly support a diagnosis of PDA? A. Cyanosis with crying. B. Continuous machinery murmur at left upper sternal border. C. Single loud second heart sound. D. Holosystolic murmur at apex. The correct answer is B. The classic finding in PDA is a continuous machinery murmur best heard at the left upper sternal border or infraclavicular area. This murmur continues through both systole and diastole as blood flows continuously through the patent ductus. Bounding pulses occur due to increased pulse pressure from diastolic runoff into the pulmonary circulation. A 3-month-old infant with large PDA is most likely to present with which constellation of symptoms? A. Cyanosis, clubbing, and polycythemia. B. Tachypnea, diaphoresis with feeding, and poor weight gain. C. Hypertension, headache, and seizures. D. Recurrent chest pain, syncope, and palpitations. The correct answer is B. Infants with large PDAs typically present with signs of congestive heart failure, including tachypnea, diaphoresis especially during feeding, and poor weight gain. The left-to-right shunt causes volume overload leading to heart failure. Feeding difficulties occur because the infant tires quickly due to increased work of breathing and increased caloric expenditure. During physical examination of a 6-month-old with suspected PDA, which of these findings is least likely to be present? A. Wide pulse pressure. B. Hyperdynamic precordium. C. Fixed splitting of second heart sound. D. Hepatomegaly in severe cases. The correct answer is C. Fixed splitting of the second heart sound is characteristic of atrial septal defect, not PDA. In PDA, the second heart sound is typically normal or may even appear single. The other findings, wide pulse pressure, hyperdynamic precordium, and hepatomegaly in heart failure, are commonly associated with moderate to large PDAs. A preterm infant born at 30 weeks gestation is now 1 week old. Which physical finding would raise suspicion for a hemodynamically significant PDA? A. Soft, non-radiating systolic murmur. B. Active precordium with bounding pulses. C. Decreased respiratory rate and effort. D. Loud, single second heart sound. The correct answer is B. An active or hyperdynamic precordium with bounding pulses suggests significant left-to-right shunting through the PDA. Importantly, preterm infants may not always develop the classic machinery murmur despite having a hemodynamically significant PDA. The increased stroke volume causes hyperdynamic circulation with bounding pulses and active precordium. A premature infant shows signs of possible PDA. Which initial diagnostic test is most appropriate to confirm the diagnosis? A. Cardiac catheterization. B. Echocardiography. C. Electrocardiogram, ECG. D. Chest radiograph. The correct answer is B. Echocardiography is the gold standard for diagnosing PDA. It allows direct visualization of the ductus arteriosus, assessment of its size, determination of shunt direction, and evaluation of hemodynamic impact. Echocardiography can also identify associated cardiac anomalies and guide management decisions based on quantifiable parameters. On chest radiograph, which finding is most consistent with a hemodynamically significant PDA in an infant? A. Right ventricular hypertrophy. B. Cardiomegaly with increased pulmonary vascular markings. C. Boot-shaped heart. D. Egg-on string appearance. The correct answer is B. Cardiomegaly with increased pulmonary vascular markings is the classic chest radiograph finding in hemodynamically significant PDA. This reflects left heart volume overload and pulmonary overcirculation from the left to right shunt. The severity of these changes correlates with the size of the PDA and its hemodynamic impact. A premature infant with suspected PDA is being evaluated. Which laboratory finding might support the diagnosis of a hemodynamically significant PDA? A. Elevated hemoglobin and hematocrit. B. Elevated B-type natriuretic peptide, BNP. C. Decreased serum glucose levels. D. Elevated liver enzymes. The correct answer is B. Elevated B-type natriuretic peptide, or BNP, is often seen with hemodynamically significant PDAs. BNP is released in response to cardiac wall stretching from volume overload. While not diagnostic on its own, BNP levels can help assess the hemodynamic significance of a PDA and monitor response to treatment, especially in premature infants. A 2-day-old term infant is diagnosed with a small PDA and no symptoms. What is the most appropriate management approach? A. Immediate surgical ligation. B. Indomethacin therapy. C. Observation with follow-up echocardiography. D. Diuretic therapy. The correct answer is C. For a term infant with a small, asymptomatic PDA, observation with follow-up echocardiography is appropriate. Approximately 60 to 70% of small PDAs in term infants will close spontaneously within the first year of life. Intervention is not indicated unless there are symptoms or failure of spontaneous closure over time. A 28-week gestation preterm infant develops respiratory distress and has echocardiographic evidence of a moderate PDA. Which medication is most commonly used for pharmacological closure in this scenario? A. Furosemide. B. Ibuprofen. C. Digoxin. D. Spironolactone. The correct answer is B. Ibuprofen is commonly used for pharmacological closure of PDA in premature infants. Both ibuprofen and indomethacin are cyclooxygenase inhibitors that reduce prostaglandin synthesis, promoting ductal constriction. Ibuprofen is often preferred because it has fewer adverse effects on renal function and cerebral blood flow compared to indomethacin. Which of the following is an indication for surgical or catheter-based closure of PDA in a 6-month-old infant? A. Small PDA with no symptoms. B. Moderate PDA with heart failure symptoms despite medical management. C. Trivial PDA found incidentally on echocardiogram. D. PDA with right to left shunting and normal pulmonary pressures. The correct answer is B. A moderate PDA with heart failure symptoms that persist despite medical management is a clear indication for closure. In infants beyond the neonatal period, options include surgical ligation or transcatheter device closure. Transcatheter approaches are becoming the preferred method when technically feasible due to their less invasive nature. A 10-year-old child with an unrepaired moderate-sized PDA is at highest risk for which of the following complications? A. Pulmonary hypertension. B. Bacterial endocarditis. C. Cyanosis at rest. D. Complete heart block. The correct answer is A. Pulmonary hypertension is the most significant long-term complication of an unrepaired moderate PDA. Chronic exposure to increased pulmonary blood flow causes progressive changes in the pulmonary vasculature, leading to increased resistance. If left untreated, this can progress to irreversible pulmonary hypertension and Eisenmenger syndrome, where the shunt reverses to right to left. Following successful transcatheter closure of an isolated moderate PDA in a 2-year-old child, what is the expected long-term prognosis? A. Lifelong anticoagulation required. B. Normal life expectancy with no activity restrictions. C. Progressive left ventricular dysfunction. D. Annual cardiac catheterization needed. The correct answer is B. Following successful closure of an isolated PDA, children typically have normal life expectancy with no activity restrictions. Complete resolution of hemodynamic abnormalities occurs after successful closure, with normalization of cardiac chamber dimensions. Follow-up is brief, usually consisting of an echocardiogram at 6 to 12 months to confirm continued closure. Thank you for joining our comprehensive review of patent ductus arteriosus. We've covered embryology, clinical presentation, diagnosis, and management approaches for this common congenital heart condition. Early recognition and appropriate intervention are key to optimizing outcomes. Please subscribe to Pediatric Case Review for more educational content and leave your questions in the comments section below. We appreciate your support.